And the parents are trained to use these feedback by the clinician so that they can deliver the treatment in a naturalistic environment. So the aim of Litcom program is no stuttering or achieving nearly no stuttering for a long time. So it aims at completely reducing stuttering as well as maintaining the fluent speech over a period of time. The program mainly has 2 stages. So stage 1 is where you have weekly clinic visits. So every week once the parent visits the clinic with the child, they have a parent-child session in the clinic where the clinician observes and gives feedback, and the remaining days parents practice at home in natural environment. The stage 2 is when the child has achieved nearly no stuttering and they are discharged from therapy, but they are followed up for longer intervals. So the gap between these follow-ups increases. So maybe after discharge, it's 1 month, then 3 months, 6 months, 12 months, it goes on. And up to 2 years is what they follow up in the Litcom program. At any point, if there is a relapse or increase in stuttering, then parents may be asked to come back to the clinic. And that is the child is coming back to stage 1 and go ahead. So how do they measure? Of course, at baseline and discharge and follow-ups, they do calculate the percentage of stuttering. But one feature in Litcom program is measuring stuttering severity. Now you can see a graph here. So this is a graph. It's a 9-point rating scale, if you can see, where 0 indicates no stuttering and 9 indicates extremely severe stuttering. Parents are asked to rate child's speech every day. So you can see the first block has a date 4, 8, 9. That's the Monday of a week. And all 7 days of the week, every day, parent have to rate the stuttering severity on this 9-point scale. So this is a nice way for parents to monitor. Okay, they are also, you are making sure that parents are compliant, they are doing the home training, and it gives a feedback to the clinician also whether the therapy is working or not. Along with this, even the clinician rate the severity once a week. So the discharge criteria they follow in Litcom is for 3 consecutive weeks, both parent and clinician severity ratings need to be 0 or 1. So it cannot be more than 1. And the percentage of disfluencies should be less than 3%. That is when they discharge, say that stage 1 is complete and the child can be discharged. So that's all about the Litcom program. The next direct treatment approach is your response cost. Now, response cost again is quite similar to Litcom program in the sense they both originate from the same ideology of operant conditioning. However, the difference is in the form of feedback. So Litcom is more of a verbal feedback, while response cost includes tangible tokens and reinforcement. So response cost again is not restricted just for stuttering. It's actually a technique which can be used with other communication difficulties also. And it's been there since long, but a structured protocol, particularly for children who stutter, was given by Dr. M.N. Hegde, and that is what we are going to see here. So unlike Litcom, now response cost is a clinician-delivered treatment. So there, parents are delivering and the clinician is only monitoring and facilitating. However, here, we as clinicians deliver the treatment. So here again, if there is a fluent utterance, you give a token to the child along with a verbal reinforcement. And if there is a moment of stuttering or a disfluent utterance, the token is withdrawn with a corrective feedback. So like this, throughout your session, you would have conducted several activities. For every fluent utterance, you token, and for every disfluent utterance, you are withdrawing the token. At the end of the session, child can count and the tokens collected are exchanged for a reward. So this reward you may introduce in the beginning of the session. You can tell the child, this is what you're going to get if you are able to meet the target. And maybe you can even give them target that I want you to collect at least 10 tokens today, 15 tokens today, depending on what is the severity of the child's stuttering and what target you have decided. So the Hegde's protocol says the phase 1, which is basically your baseline assessment, where you do a detailed assessment of all the parameters, which we saw last week in Santosh sir's presentation. The second phase is establishment, where you are actually starting the treatment. So as per Dr. Hegde's protocol, the treatment happens at 4 levels. So you start at a sentence level, then move on to continuous speech, followed by narration and conversation. So in the how do you transition between these stages? Like when do I sentence to continuous speech? We do it when, as per the protocol, when you have less than 2% disfluencies for at least 3 clinic sessions at the sentence level. That is when you move on to the continuous speech level. Again, you practice at the continuous speech level. And when you meet this criteria of less than 2% disfluencies for at least 3 sessions, that is when you move to the next level. So like that, we practice from sentence, continuous, narration to conversation. Now you may encounter some children where at the sentence level itself, they are finding it difficult. So you may not, they are only having stuttering and you're not even able to give them any reinforcement for the fluent speech. So the program does give a flexibility that you can step down and maybe carry out some activities at a word level. So you have a word level task where the target for the child is to say a single word or maybe a 2-word phrase fluently, and you reinforce. That would increase motivation in them, confidence in them, and that is then you can move on to the sentence level. So like Litcom, again, the third phase is maintenance in response cost as well. When do we move to maintenance phase? When you have completed all the 4 levels from sentence to conversation with at least less than 2% disfluencies for 3 clinic sessions and less than 5% disfluencies in the natural setting is when you move on to the maintenance phase. What happens in maintenance phase? Well, preferably you there's less than 1% disfluency, so it's basically no stuttering at the time of discharge. Maintenance phase, you promote self-evaluation. So you have trained the child that even if they encounter a moment of stuttering, they are able to self-correct. You train the parents on home training. So monitoring the child's disfluencies, how well the child is doing, what are the situations the child finds difficult. You train the parents and they are supposed to monitor all that in the maintenance phase. Again, the phase 2 was happening mostly in the clinical setup, which is a very structured situation. So the goal of phase 2 or the aim of phase 2 is to move from less structured to naturalistic settings. But during this phase 3, if need be, you can give booster sessions to the child. And finally, again, response cost also suggests to do follow-up. So you can have follow-up 1 month, 3 months, 6 months, up to a year. Maybe difficult to follow up a child up to 2 years. Some of the parents may not come back, and especially if the child is completely recovered, but at least try following them up to 6 months to 1 year. So these are just some exemplars. Now, we said for every fluent utterance, you give a token and you take one back. So what are these tokens? These can be anything. It's all up to your creativity and the child's interest. So I have some of the pictures here. So you can see we all have these threading beads in our therapy kits, right from our bachelor's, we have it. So you can include these. So for every fluent utterance, child gets a bead, which he threads. And if disfluent, you take one. You can stack coins. You can maybe stack Jenga blocks. You can have a reward chart where you can give them stickers or stars. So any of these you can use. Some examples for the activity. So we saw there are 4 levels. Okay, now activity again, need to make sure that it is based on the child's interest, their language level, their cognition level, all of that. So sentence level activities could be you have picture naming kind of task, but where they play a game, I see a, and they describe whatever they see. Or it can be some things they like, food items they like, and they pick a chit or pick a picture and they say, I like ice cream because. So you're trying that the sentence is long enough, and it can be like a game. So make sure it's play-based kind of a therapy. So turn taking is happening between you, the clinician, co-clinician, parent, whoever is available for the session. The second level is continuous speech levels. You can have tasks like picture description or again describe me, where they need to describe whatever they pick in a chit or something in maybe 3 to 4 sentences. Then you have narration, where you can have stories. You can ask them to narrate their routine, some recipes, or a procedure or an incident. Lastly, conversation level, you can have a general conversation with the child as well as role plays to make it interesting. So these are just examples. You can be more creative and include whatever activities you feel the child may enjoy. So a word of caution, when we are using response cost, so we know we are giving tokens and withdrawing tokens when the child stutters. So avoid token bankruptcy. That is, at any point, it shouldn't happen the child is left with no tokens at all, because that may really demotivate them and they may not want to come for the therapy session. What you can do, you can increase the frequency of tokens which you give for fluid utterance and reduce the withdrawal frequency. So simple words, if a child is having a fluent utterance, maybe give them 3 tokens. But for every disfluent utterance, you withdraw only 1. So that way, you can ensure that at the end of the session, child does have some tokens remaining. Another, token withdrawal you may experience negative reaction. So in the beginning, initial stages of therapy, the moment you withdraw a token, the child may throw tantrums. They may just refuse to cooperate. They may walk out of or run out of your session, or they may cry. So to avoid any of these, you can do role reversals. So you become the client and you make the child become the therapist. You take turns. So you say, and you purposefully token or take it back from you, and they may really enjoy that. But that would facilitate cooperation for the technique as such. Also, remember to use verbal reinforcement and corrective feedback. So in the process of giving and taking tokens, please don't forget to reinforce verbally, that is, use a praise when they are fluent and give a corrective feedback when they are disfluent, because this will help you fade tangible tokens. Eventually, we want them to be fluent, and not in all situations, parents can carry tokens with them and keep giving it. So whatever behavior change tokens are bringing is what we want a verbal feedback to do. So that's about response cost. Now, few other techniques which can be tried are, especially for the 5 to 6 years range, I would say, that is prolongation and pause and talk, or modified airflow, as some of you mentioned. Why I say 5 to 6? Because children below the 5 years may not really comprehend the instructions. Some of them may, but the very young ones may find it difficult to follow what exactly needs to be done in prolongation and pause and talk. And I'm not getting into the details of these techniques. They're mainly for school. Dr. Rakesh will be talking about these in his presentation next week. So with that, we complete the direct approaches. Now moving on to the hybrid approaches. So the first one is parent-child interaction therapy. Now it is developed in the Michael Palin Center for Stammering Children in London, and it's a multifactorial model. So by multifactorial, they basically believe stuttering is not caused by one thing. There are multiple variables or factors which, when interact together, lead to stuttering. So these factors are classified as psychological aspects, that is child's temperament, how sensitive is the child, as well as the parent's anxiety. Physiological factors, so that is the gender. We know research says that male tend to stutter more when compared to females, genetic history, and the motor skills. The third factor is your language development. So if the child has very good receptive expressive language skills, then maybe coping up with stuttering becomes easier, and vice versa. Lastly, the environmental factors, which includes the pace of life, the communication interaction at home, the parents' language complexity, that is the kind of language parents use when talking to the child. So parent-child interaction therapy again suggests to do a detailed baseline assessment before you start therapy. And the goal of this program is triad goals. So you have first goal as to reduce stuttering. Second goal is to reduce the parental anxiety. And third is to increase parental confidence in managing stuttering. How do they do that? So there are different strategies. You have interaction strategies, family strategies, and child strategies to deal with these factors which influence stuttering. So here are some examples. So interaction strategies, and family strategies will fall into the indirect approach component. So remember, this is a hybrid approach. It's using both indirect and direct principles. So the interaction strategies and family strategies are adapted from the indirect principles. So interaction strategies follow the child's lead, use more comments, pause, praise, reinforcement. Family strategies is turn taking, dealing with feelings, and openness about stammering. That is, it's okay to accept that the child has stuttering, and also to make the child feel that it's okay to stutter, we can overcome it. The last set is the child strategies. These are more of a direct approach where you are directly working on the speech production of the child by using rate reduction strategies, asking them to pause, to think, teaching them easy onset, so easy voice onset or easy articulatory onset, being more concise, and maintaining attention and eye contact. The second hybrid approach is Restart DCM. This is based on the demands and capacity model. Again, very similar to PCIT, DCM also believes that there are multiple factors which play a role in stuttering. So they classify these factors as motoric, linguistic, social, emotional, and cognitive factors. And the basic premise of this model or this approach is, as the demands reduce and the capacities increase, the child is going to be fluent. If the capacities or the skills, abilities of the child are not able to match up to the demands and the demands are exceeding the capacities, that is when the child will stutter. So the speech therapy which is given under this approach, it focuses on the behavior changes, coping with how to cope with emotion and skills training. So here what they do, they first focus on the indirect aspect. You first change the environment and deal with the feelings. And if that fails, then you go for the direct approaches. Again, this program has two phases. So you can see there's a pattern. All the programs, you have establishment and maintenance. Establishment is when you are teaching the treatment techniques to the parent, or if it's a clinician delivered treatment, you are delivering it yourself. Now, Restart DCM again is more of a parent delivered. So weekly clinic visit, and the remaining time parents are practicing the strategies at home. Phase 2, once the child is discharged, they are followed up to 2 years. Now, weekly sessions, they are 1 hour sessions. What happens in these sessions? These sessions are used to identify the demands and capacities and discuss and implement the strategies. So you identify what are the demands placed on the child, what are the capacities or skills of the child, and then you discuss with the parents and come up with strategies. In what ways can you reduce the demands and increase the child's capacities? Along with that, you have something called parent-child special time, which is nothing but a dedicated interaction between the parent and the children happening in the clinic during that 1 hour visit. And you ask them to carry it at home as well for 5 days a week. One session is like 15 minutes, and maintain logbook of this. So parents maintain what interaction was, what topic, what task, what were the demands they placed, and how was the child's response, how many instances of stuttering were noted. So a typical session is clinician observing the parent-child interaction, discussing progress, and planning for the following week. So that was an overview of the techniques. We saw conventional techniques, analogies, which focus more on manipulating the speech subsystems. Then we saw indirect approaches, where it's all about parent counseling, guidelines about changing family interaction styles. Then we moved on to the direct approaches, where we saw Litcom program, which is verbal contingencies, and response cost, which is focused on the token economy. Lastly, we saw the hybrid approaches, that is parent-child interaction therapy and demands and capacities model, where the focus is on improving the child's skills and reducing the demands placed on the child. So now we'll see some of the considerations we need to take care when we are making decisions about treatment. Goal setting. Now we know the child needs to be intervened early. We saw there are a lot of options in terms of techniques, but what should be my goal for therapy? So of course, it's a fluency disorder. You need to have fluency goal. So your goal is to reduce stuttering less than 3% of syllable stutter, because it's considered anything more than that is stuttering. And Also, to reduce the stuttering severity, so reducing the percentage of syllable stutter and reducing the stuttering severity. Just establishing these in the clinical setup is not enough. Maintenance is equally important, or rather more important. So your goal also has to be maintaining the attained fluency skills in beyond clinic situations and over time. And lastly, to manage the feelings and attitude. So both parents and children may be experiencing anxiety and nervousness, fear, a lot of those issues. As a clinician, you need to help them to manage those as well and improve the child's confidence and motivation. So now we know what the goals are. How do I select the treatment approach? We saw direct, indirect, hybrid, but which one do I choose? Well, the selection of technique is based on a lot of factors. It depends on the nature and onset. The stuttering started at what age, and after how many days, weeks, or months have the parent brought the child to the clinic? What is the severity? The general development of the child, the language skills of the child, environmental factors, awareness, attitude, and your expertise. As clinician, do you prefer using one, you feel your expertise is more in a particular approach? So all these factors matter when you are choosing the treatment technique. Now, if you have a child who's having borderline stuttering, and the stuttering is mainly more like a episodic or fluctuating in nature, so you can start with indirect approach where you are manipulating the environment and then move on to the direct approach if need be. So when to transition from indirect to direct? How do I know that indirect is not working or it's not enough? See for 3 to 4 weeks. So try indirect for 3 to 4 weeks. And if it's not working, there is no change or the stuttering is still persisting, you need to start with the direct treatment approaches. But in case of children who have well-established stuttering, so when the child was brought to you, they already have maybe moderate or more than that severity of stuttering, you can straight away go for direct approaches or hybrid approaches. So the next decision needs to be made is treatment dose and discharge criteria. For how many months should the child come and when do I discharge the child? So research says, and I personally feel, that intensive sessions are better. Now, this, when I say intensive, remember Litcom program, it has only one weekly visit, but it is intensive because parents are giving treatment on an everyday basis. So intensive is better than distributed practice, a minimum of 4 sessions per week. So we should try to incorporate a minimum of 4 sessions per week. And the ideal duration for a session would be around 45 minutes to 1 hour. Discharge criteria, similar to what we already saw in all the programs. So less than 3% syllable stutter in both within and beyond clinic situation, and a severity rating of 0 or 1. So if the child is meeting this criteria for 3 consecutive sessions or for 2 weeks, you can discharge the child and then conduct follow-up evaluations. So moving on to the progress. How do you measure or gauge the progress a child has made? Well, there are different, it's always better to use more than one measure or parameter. So percentage of syllable stutter, this can be measured weekly or fortnightly. So the formula, total number of syllables spoken into 100. So you can video record the session and you can daily severity ratings. We can definitely start using these. So this program, this art, which is given by Litcom program, the template is actually freely available on their website. So you can just download it and you can use it, give it to the parents as well to mark it. So the graph, parents will also get a very good visual representation of their child's progress. Along with that, we can use any standard naturalness rating scale. So we have one in SSI 4, we can use the same. And also there are some parent perception or parent satisfaction questionnaires available where parents tell whether they are satisfied with therapy or not. What is the impact of stuttering on the child? So some of these questionnaires are available. If you want, you can use them as well. So that was about stuttering. Now, one question which was also asked in the last webinars, do we treat normal non-fluency? So I would say the answer is both yes and ideally we would expect a child to overcome normal non-fluency. It is a part of a developmental process. So they should be able to overcome it as and when their language skills and the speech motor skills develop. But in case you encounter parents over concerned, anxious because of the child's non-fluency, and use some of the principles of direct approach. Now, please remember, as it was told in the last week's webinar also, normal non-fluency and stuttering are two different entities. The type of disfluencies which you see in normal non-fluency are different from that what you see in stuttering. So, but just in case you want to, you can use indirect approach that would help to provide a favorable environment to the child and reduce the parent anxiety. So in a nutshell, we have moved from wait and watch approach. Maybe long ago, people did believe that if you have a very young child who walks into your clinic, they may not, you may say that we'll see, child may overcome, or a lot of time parents, grandparents at home may say no, they will overcome over time. But no more wait and watch is believed in, and we should start early intervention. Remember, one size does not fit all. So what I gave is just a protocol, but you can be flexible and make a tailor-made intervention based on your child's need. The treatment delivery, it has to be systematic yet flexible. So systematic, yes, you need to choose right goals. You need to have a proper structured way of delivering therapy, documenting the progress, the reinforcement schedules you use. There has to be a structure in it, but based on the child's responses and the needs, you can make minor changes to the protocols. So that is the flexibility I talk about. And gradual increase in task complexity. So in response cost, we start at sentence level, continuous speech, narration, and conversation. That is a general protocol we can use in terms of choosing our activities, irrespective of what techniques you are using, but make sure there's a gradual increase in the task complexity. And lastly, efficient counseling. So counseling is very, very important. You need to counsel the parents really well so that they are cooperative and they are contributing to therapy, whatever they're expected of. So with this, we come back to our questions, which we saw in the beginning. Now let's see if we could answer them. So the first question we posed was when to start treatment. Answer is at the earliest. Which technique can we use? So it's an eclectic approach, tailor-made, custom-made. You can use only indirect, only direct, or a hybrid, depending on the needs of the child and the profile of the child. When do I discharge the child, or how many of sessions are enough? Well, do not fix the number of sessions, fix the discharge criteria, establish less than 3% disfluencies across situations for at least 3 sessions or 2 weeks, and that is when you discharge the child. How do I measure progress? Use multiple measures. Do not stick onto only one criteria. So as I mentioned, percentage of syllable stuttered, severity rating by the parent, by the clinician, naturalness rating. Try using more than one measure. And lastly, should I treat NNF? You can, if you have to, using the indirect approaches. So that's all from my end. With this, I would like to thank ISHA SIG Private Practitioner Groups, the organizer, for this webinar and for giving me the opportunity to be a part of it. Dr. Santosh, my guide and mentor, I think he's the one who kindled interest in me for Fluency. ISHA office for all the technical support. My department here at Mangalore, KMC, for all their encouragement. And most importantly, the participants for today's webinar, for all your patient listening. So thank you one and all. And if there are any questions, I am happy to take them.
Thank you, Dr. Divya, for such a wonderful and enriching presentation. So I am also a firm believer of early intervention, whether it's hearing loss or it's autism or it's stammering for now. So we have a few questions in the chat box. The first of them asked by Mr. Chandan is, how many follow-up sessions would you recommend?
As I said, if I go as per the literature and evidence-based practice, most of the programs have been following up to 2 years. They definitely increase the duration between the visits. So initially you would call them 1 month, every one, like maybe for the first 3 months, you call them every month. Then it's only after the 6 months, and after 6 months, it's only after 12 months. So the duration increases, but they recommend to do it up to 2 years. But the Indian mentality, I would say not many people would follow up. And that was a challenge I faced when I was doing my study. And especially they'll not come if they are treated. If the child is not having any relapse, which we hope for, they may not come back for follow-ups, but we should try to follow up at least up to a year. Maybe it's okay to do just a phone call or a video call follow-up. It's okay if they're not able to come for a clinic visit. We have the technology now. So you can ask them to just record the child's video and send it to you, and you can just see whether the child is maintaining the skills which were attained.
All right. That takes me to another question from here. How long normally does it take to treat? Because for the first session, when we are into private practice, the parents would ask us how long this treatment is going to take. So what is your take on that?
It will depend on, when I counsel parents, I usually say, see, each child is different. So I cannot guarantee you that it will get done by these many weeks or these many days. It depends on, again, it also depends on the severity of stuttering. So if you have a child who has mild stuttering, then maybe intensive sessions, that is 4 to 5 sessions per week, if you're taking, you can see improvement within 1 to 1.5 months. Most of the children which I saw, they have recovered within 1 to 1.5 months if they're taking around 4 to 5 sessions per week. Okay, but if the severity is more, it's moderate or severe, and if they have a lot of other emotional issues associated, anxiety is more, secondary behaviors are more, they have blocks, and they struggle to come out with speech, then it may take up to 3 months or more than that.
All right. And what is the severest case that you have encountered and you found a little difficult to manage, and you had to put in all the hybrid approaches? If you could just mention about it in maybe a few seconds.
Yeah, so the most severe case I saw was a child who was 4.5 years old. And but the onset of stuttering was around 3.8, I think. So they came for therapy only when the child was already having stuttering for the past 6 to 8 months. And it was severe stuttering. He had severe stuttering. Literally every word he said, he stuttered. And more in the beginning stages, most of them tend to have a lot of syllable repetitions or part word repetitions. That is what you see in most of the children of the preschool age when they develop stuttering. But this child, because it was quite well established, he had a lot of blocks. So more than the repetitions, it was blocks. And I personally felt blocks are more difficult to treat than repetitions. So if the child has only repetitions, you can see a fast recovery. But if the child has blocks, it takes more time. And only one particular approach, like only using direct approach, may not work. You need to use a hybrid approach in that case. So that is what a lot of counseling had to be done for this child, along with I used response cost. So because mine was a research study, it was supposed to be a very idealistic environment, and I had to stick on to a lot of things, not use a combination of approach. But yes, in a clinical practice, I would say combination is the best.
Is the best, okay. Another question from Mr. Sanjeev is, can we try giving online option for preschool children to avoid clinical setup and in turn making them conscious about their stuttering?
Well, teletherapy has been working really well. And the Litcom program, which is meant for preschool, they have also been doing teletherapy for the last 4-5 years or more than that now. And they have told that it's equally good. I mean, the results they got in their one-to-one therapy sessions, in-person sessions, same improvement they have found in teletherapy. But Litcom is a parent-delivered treatment. So if you are training the parent, you are incorporating principles of Litcom, and you're going to train your child's parent to do, then you can go ahead with teletherapy. You can ask them to visit, at least if they are local, ask them to visit weekly or fortnightly once to the clinic. But if you are using a direct approach, like response cost, then it might be difficult to do it through teletherapy.
Yeah, because the tokens and the reinforcement.
Yeah, tokens. I mean, you can still have online tokens, some softwares and platforms which promote, again, access. As private practitioners, how much access do you have to these softwares? And children that young, how much are they going to cooperate? I mean, maybe the 5 to 6 year age, they may do it. Owing to COVID and all the school happening online, they've got used to sitting in front of a screen.
True.
But the very young ones, if you have like 3 to 4 years, or if you happen to have a child who's less than 3, then online might not be very feasible.
Okay. Next question, again from Mr. Chandan, is what's your take when stuttering coexists with misarticulations or maybe phonological disorders? So what should we treat first and what should we treat next?
I mean, I think Santosh sir partially answered last time. So there is a big chunk of children who have comorbidity, that is, they have stuttering as well as phonological issues or phonological disorder together. You treat both. You do not choose, I treat this first and this later. No, from the beginning, you treat both. You can divide your session into language, the phonology therapy, as well as the fluency therapy. And maybe you can be creative and have some activities where you are able to tap onto both.
Yeah. Are there some softwares that can be used for teletherapy that you would recommend?
I mean, I haven't personally used any softwares so far. Mine was in-person, in-clinic therapy. There are some softwares which are available, but again, most of them available are for adults as of now, like whatever is available in Play Store. So they have more of pictorial representations, and a lot of self-monitoring apps are there. So you have metronome and pacing, things like in self-monitoring, but that may not really work with the children.
Okay, agree to it. Next question by Ms. Reno is, what is the percentage of stuttering cases not recovered or relapsed?
Preschool children, if I say, I mean, I am not aware of any proper research studies done, but now if I take the example of my study, I had 30 children, and out of 30 children, I think all of them recovered. Of course, the number of sessions they needed varied. So the earliest was 20 sessions, and the maximum I gave was almost 50 sessions, okay, which was spread across 3 months. And relapse, I followed them up to 6 months. So up to 6 months, there was not really a relapse. There were, I think, 2 children who had a slight increase in their stuttering. So it became around 3 to 4%, which is again not very high. After 1 year, I'm still in touch with many of them. So after a year, there was one child who had a relapse.
And I have also seen that some children, they would leave maybe the parents would not like to continue once they see a lot of improvement in the child. That is one cause of relapse, isn't it?
Yes. Yes. A lot of parents, I mean, they have their own financial issues, work commitments, and all of that. So the initial improvement, what you see, the graph is quite steep. Sudden improvement will be there. There'll be a sudden drop in disfluencies. But
yes,
to achieve that maintenance, you need time. And when parents see so much of improvement in the beginning, they feel, okay, the child is recovered and we can manage it at home, and they tend to not come back for therapy. So there is a high attrition rate as well. That is what I think maybe we are lacking in our counseling. So we need to make sure that we counsel them well. And if you have already, you can have testimonials from some well intervened cases and parents. So maybe you can show those testimonials or put these parents into touch so that they will also motivate them to continue treatment till the clinician asks for it.
Oh, right. We can have video recordings from with the consent of the parents if they want to. Yeah.
Yes. That's why I said follow-ups would work. So even if we can even tell the parents explicitly that at any point, if you feel you're not able to continue therapy, please let me know. I mean, I understand you have your own reasons for not being able to come, but we can figure something out. So at that point, if you're using direct approach, we can incorporate principles of something like Litcom. Train the parents, let them carry it out at home, and at least maybe then they'll keep in touch, they'll keep sending the videos or come for follow-ups so that the child is benefiting.
All right. Next question. We have a lot of interesting questions. So the next question from Ms. Zainab is, parents of 2.5 to 3 years old frequently have a concern if the initiation of treatment would increase awareness and subsequently the stuttering. So how do we go about it?
Yes, a lot of people questioned that. Don't you think if you use direct approach with such young children, you are making them aware of it? But I feel if the child already has mild to moderate stuttering, they are aware of it.
Yeah.
Okay, maybe we are not able to understand that, we are not able to gauge it, but the child is aware of it. If parents are too anxious, you can tell them, okay, we will right now start with indirect approach. So we are not really telling anything to the child. And once the parents' anxiety levels are dealt with, you can introduce direct approaches. Also, you can tell them, see, Litcom or response cost, most of it is play-based therapy. So, and even response cost, you are only giving contingencies, tokens, taking it back, but nowhere I'm telling the child that you're speaking wrong, you're not speaking correctly. Neither am I telling that, nor am I changing the way the child is talking. I'm not teaching them prolongation. I'm not making them drag their speech. You do things like that, that will make them more aware and maybe self-conscious, because they may not want to talk like that in front of everybody.
So if I can put it in a few words, that we just make up on or maybe try building up on their confidence.
Yes.
While they talk.
Yes.
Okay. Thank you for that answer. Next, we will take 2 more questions.
Okay.
And the next question is, if the child was discharged at the age of 5 years after a treatment of stuttering and happened at the age around 7 years, so then how do we go about it?
If the child was discharged at 5 and then relapse happens at the age of 7.
7 years.
Okay, I think Dr. Rakesh will be answering that in the next week.
In the next one.
He's going to, now the child is school age.
Yes.
We need to take up approaches which work well with for school age children. So yeah, maybe please register for the next webinar if you haven't already.
We will have to wait for the next speaker then.
Yes.
And another question from Falguni. Would you use prolongation for children who have repetitions or blocks? Preschool children?
Preschool children, as I said, I personally felt only the ones above 4.5 to 5 would be able to follow it. Younger than that may really find it difficult. And I would use it more for the ones who have blocks. The ones who have repetition, they usually tend to improve with just the token and the verbal contingencies and modeling correct speech. So basically, see, the reason for my personal, you are inducing some kind of a non-natural form. A lot of parents are also concerned about it. And children, if they're too aware, they don't want to talk like that in front of everybody. So they might do it in your session, but they'll not practice at home or when they are at school or anywhere else. So as much as possible, try to take up techniques where you're not altering the natural prosodic aspects of the speech. But of course, I said blocks are difficult to treat. I did find it challenging. And if the child has significant blocks, then yes, you need to include prolongation or maybe a combination of modified airflow with prolongation.
So also, do you recommend group therapy? We understand that all children are different, but is there a stage that maybe if we have a lot of caseload, luckily, and then we want to have maybe 2 or 3 kids together or maybe 4 kids together for a group therapy session?
We can try group therapy. Again, I mean, if I talk from a evidence-based practice point of view, there are some studies which are done, and they did say that group therapy has shown improvement. But I would not recommend group therapy for a child right in the initial stage. I mean, just after the diagnosis, you need to have some amount of one-to-one therapy, and only then would I put the child into a group session.
All right, but does it show results? Because I understand in the initial stages we cannot, but and how many sessions, or if you could say 2 lines about group therapy?
Personally, I don't have experience of group therapy for children. I haven't conducted it, but from what I have read about it, they would, again, a small group. So you can have maybe 4 to maximum 6 children in a group, not more than that. And try to have children, again, try to have a homogeneous group. So if you have a child who has only mild stuttering and another who is severe stuttering, it might be difficult.
Yeah,
so,
yeah.
Again, try to group them based on their severity. And of course, in our setup, language and all those other things. Session-wise, you can maybe have the first 10 to 15 sessions, at least 10 sessions of one-to-one therapy for the child, and then introduce them to a group session. And then even your group and individual sessions can go in parallel. So maybe out of 3 sessions in a week, which a child is attending, 2 is one-to-one session and 1 is your group session.
Okay. Thank you, Dr. Divya. And I request all the participants, if you have more questions, you can email Dr. Divya. The email ID is right in front of you on the screen. And in India, as we know, about 11 to 12 million people are stammerers, are stutterers, and speech therapy is an integral part of this population. So we hope while we start early intervention, we can definitely reduce this number. Thank you, Dr. Divya. I would really like to thank you for such a wonderful presentation.
Thank you.
I would also like to thank ISHA, SIG, my advisors and my teammates for their constant encouragement and their timely support. Shweta from ISHA back office. And I would also like to thank the delegates for being there and for their great questions that they have asked. It is because of such active participation that we feel motivated, and you all are the wings beneath our wings. We now look forward to the next Fluency Friday webinar on the 16th of September. And the key speaker will be Dr. Rakesh CV, Assistant Professor at Manipal. And the session will be moderated by Ms. Disha and Mr. Bhaskar Dev. So let us, if you have not registered, please register for it and let us meet again after a week. So thank you, everyone.